Hello and welcome to the topic Mitral Stenosis in the Cardiology module. By the end of this topic, you should be able to define mitral stenosis, explain the causes and pathophysiology of mitral stenosis, classify mitral stenosis, describe the clinical features of mitral stenosis, and outline the principles of management of mitral stenosis. Let's get started. Mitral valve stenosis refers to a narrowing of the mitral valve which obstructs the filling of the left ventricle. It is said that the causes of mitral stenosis are rheumatic fever. Rarer causes that may be seen in the exam include mucopolysaccharides, carcinoid, and endocardial fibroelastosis. However, the most common cause of mitral valve stenosis is still rheumatic fever, which however may date back many years. Therefore, asking the patient about the history of frequent bacterial tonsillitis is important. Rarely, there may be congenital stenosis in the mitral valve area as well. The three grades of severity of mitral stenosis here depends on the remaining open area, mean pressure gradient, and mean pulmonary capillary pressure. Stenosis can be divided into the severity grades of mild, moderate, and severe. The mild grade has a pressure gradient of less than 7 mm mercury, an opening area that is between 1.5 and 2 cm square, and a mean pulmonary capillary pressure of less than 20 mm mercury. The moderate grade has a mean pressure gradient of 8 to 15 mm mercury, an opening area of 1 to 1.5 cm square, and a mean pulmonary capillary pressure of 21 to 25 mm mercury. In severe mitral stenosis, the mean pressure gradient increases to more than 15 mm mercury, the opening area drops below 1 cm square, and the mean pulmonary capillary pressure rises to more than 25 mm mercury. So what happens in mitral stenosis? Because of stenosis of the mitral valve, the blood cannot flow properly into the left ventricle. Thus, this causes a blood stasis in the left atrium, and the blood flows back into the lungs to the pulmonary veins and ultimately in the right heart. Therefore, there is a risk of right heart failure and an increased risk of atrial fibrillation due to the overstretching of the left atrium. Atrial fibrillation may increase the risk of embolization and may result in acute ischemia of the legs, stroke, or mesenteric ischemia. The severity of the disease determines which symptoms occur. The expansion of the left atrium may lead to atrial fibrillation and thrombi, and therefore to arterial embolisms. Due to the congestion of the blood in the lungs, this leads to pulmonary hypertension with symptoms such as dyspnea and nocturnal cough. Signs of right heart failure may also occur, and these include reduced cardiac output, which leads to performance degradation, fatigue, peripheral cyanosis. A late finding and a bad prognostic factor means that the right ventricle can no longer keep up with the increased pressure transmitted backwards from the left atrium. On physical exams, it will reveal right ventricular heave with the patient having pulmonary hypertension. Mid-diastolic murmur is also audible. And remember, the blood flows across the mitral valve and into the left ventricle during diastole. It's heard loudest at the mitral area, which is at the apex and has a rumbling characteristic. It radiates towards the axilla and an opening snap as the calcific valve is forced open by the left atrial contraction. Atrial fibrillation may be a consequence of dilated left atrium. During auscultation, a loud first heart sound as well as a split second heart sound and a mitral opening snap can be heard. A mid-diastolic rumbling murmur, which can be best heard over the cardiac apex. A sign of reactive pulmonary regurgitation, which is the Graham-Steele murmur, can be heard. An ECG may show a P with double peaks as well as a right ventricular hypertrophy mark and a right axis deviation. A radiograph may also show a right heart enlargement as well as an enlarged left atrium and mitral configuration. During echocardiography, the valve can be readily assessed and quantified on the grade of stenosis, which can be done. In addition, cardiac catheterization can be performed for evaluation. Cardiac catheterization is now indicated when a discrepancy exists between clinical and echocardiographic findings. The patient with associated severe lung disease and pulmonary hypertension, in whom mitral stenosis has contributed to their symptoms, need to be ascertained. In older patients with severe mitral stenosis, cardiac catheterization is strongly indicated to rule out presence of concomitant coronary artery disease. In patients who develop serious symptoms after mitral commissurotomy, cardiac catheterization may be indicated. When it comes to treatment, conservative treatment options include drug treatment of heart failure and maintaining a normal frequency sinus rhythm, as well as thromboembolism and endocarditis prophylaxis. The catheter method offers the possibility of mitral valve valvuloplasty, which can help avoid a large surgical intervention. Surgical repair or replacement of the mitral valve if the patient stays symptomatic despite medical treatment. Mitral valve replacement is a surgical treatment approach which is indicated with moderate stenosis or with a failure of valvuloplasty. Atrial fibrillation occurring as a complication of mitral stenosis should be treated. Anticoagulation treatment and consider restoration of normal sinus rhythm. Treatment of fluid overload with diuretics should be done. Let's summarize. Mitral stenosis is the narrowing of the mitral valve which reduces the filling of the left ventricle during diastole. Similar to other valvular heart diseases, it's commonly caused by rheumatic heart disease or endocarditis. Diagnosis begins with clinical suspicion of the condition. Characteristic clinical findings are mid-diastolic murmur over the apex, atrial fibrillation, and signs of increased left atrial pressure. Diagnosis is made following an echocardiogram, which provides information on the severity of the valvular defect. Treatment can be divided into medical and surgical modalities. Medical therapy is targeted at controlling heart failure symptoms and prevention of venous thromboembolism. Surgical therapy is indicated for those who fail medical therapy or has moderate to severe mitral stenosis. We have come to the end of this topic. Thank you.